Good afternoon, dear colleagues. Our today's lecture is devoted on topic diseases of gastrointestinal tract. Gastrointestinal tract is the most important part of digestive system. Total length of GIT is nearly 9 meters and total area of the small intestine only reach 250 square meters. That can be comparable with the football field. Gastrointestinal tract is the most important part of digestive system. There are two large glands, including liver and pancreas, and billions of microorganisms, multiple enzyme systems, and GIT, which are necessary to properly digest food and extract from it the most necessary nutrients for our organism to survive. Pathology of gastrointestinal tract is one of the most widespread and important group of diseases which are characterized by the diversity of clinical and morphological features. They include primary diseases and secondary diseases, which can be manifestation of a number of infectious and non-infectious diseases or acquired or hereditary origin they have. Basis for these diseases could be such general pathological processes as ulceration, inflammation, hyperplasia or dysplasia, autoimmune disorders, and, of course, tumors. First disease that we will investigate with you is tonsillitis or sore throat. It's usually infectious disease with severe inflammatory changes in the lymphadenoid tissue of the throat and tonsils. Usually tonsillitis is associated with numerous pathogens of bacterial, viral or fungal origin. Bacteria, the most important for such disease, is beta hemolytic Streptococcus group A, less common Staphylococcus, and combination of Strepto and Staphylococcus. In childhood, one of the most important role belong to Corynebacterium diphtheria, and such infectious disease like diphtheria plays the increasing important role nowadays because there is pre-epidemic situation with such infection. There are a lot of people who can't be prevented with vaccine or who migrate from poor countries and have no such vaccination against Corynebacterium. That's why nowadays diphtheria begin to play very important and can become dangerous problem in the nearest future. Speaking about viruses in etiology of tonsillitis, we need to remember about adenoviruses type 1, type 9, less common Coxsackie enterovirus, herpes simplex virus, and so on. Spirochaete vincent in some symbiosis with the spindle rod can cause separate variant of tonsillitis which is named pseudomembranous tonsillitis. From fungi we need to mention Candida species in symbiosis with pathogenic cocci. Contributing factors in tonsillitis are local and general hypothermia, decrease in local and general immunity, tonsil stroma, violation of nasal breathing, chronic inflammatory processes in the oral cavity, nasal and paranasal sinuses. Classification of tonsillitis can divide such disease into acute and chronic variant. Clinical morphological variants of acute tonsillitis are catarrhal, fibrinous, purulent, necrotizing, and gangrenous. Separate variants of acute tonsillitis are lacunar, follicular, herpetic, and pseudomembranous Plaut's tonsillitis. Chronic type of tonsillitis can be subdivided into lacunar, lacunar parenchymatous, phlegmonous, and sclerotic. Morphological types of tonsillitis we begin to study from catarrhal variant. It's a relatively mild form, duration of this disease usually from 3 to 5 days. Palatine tonsils are slightly increased and covered by hyperemic mucosa. Cervical regional lymph nodes are slightly enlarged and tender. Mucous membrane of the tonsils and palatine arches is plethoric or cyanotic, dull, usually covered with mucous exudate, which is typical for such type of inflammation. A lot of leukocytes can be detected microscopically. These leukocytes mostly neutrophils with admixture of macrophages. Sometimes exudate raises the epithelium and forms small bubbles with muddy contents. Fibrinous variant of tonsillitis, most typical for diphtheria, which was mentioned above. In this disease, tonsils are enlarged, their surface is covered by grayish or white films. Type of inflammation may be both lupus or diphtheric. Usually it's diphtheric type of inflammation, when we can find the deep necrosis of the tonsil mucosa with infiltration by fibrin and leukocytes. Tonsils macroscopically look like enlarged, hyperemic, and are covered with dense films. Detachment of these films can cause ulceration and sometimes bleeding. Cervical lymph nodes are enlarged and swollen. Microscopical picture is represented on this microphoto. As I told before, we can find the area of necrosis, reddish pinkish in color due to impregnation of fibrin threads, and multiple leukocytes are present. Partial atrophy is seen here, and demarcation inflammation zone on the border of necrotic area and healthy area. In this demarcation zone, we can identify multiple neutrophils. Another picture of diphtheric tonsillitis. Small and large magnification of the same tonsil. With digit 1, it is indicated necrotic zone impregnated by fibrin threads. With number 2, we can see the area of demarcation inflammation with plethoric blood vessels, edematous changes, and severe infiltration by neutrophils and macrophages. Follicular and lacunar variants of tonsillitis. These forms are characterized by severe clinical presentation. Usual duration of such types is about 5 to 7 days. In lacunar variant of tonsillitis, process begins within the mucosa of lacuna. Serous mucous exudate accumulates in extended lacunae. Exudate protrudes from the lacuna to the surface of bright red, hyperemic and enlarged tonsils in a form of whitish-yellowish corks. Lacunar tonsillitis is characterized by ulceration of lacunar epithelium, leukocytic infiltration of the mucosa, thrombosis of the small vessels, and separation of the lymphoid follicles. Typical picture of lacunar tonsillitis you can see on these two photos. Follicular variant of tonsillitis is characterized by a primary lesion of the follicles. Tonsils are enlarged at hyperemic. Small yellow suppurative follicles can be seen on their surface. There is separation of the follicles and their hyperplasia with germ centers. These germ centers in microphoto looks like clear area in the center of lymphoid follicle, and they are associated with intensive proliferation of lymphocytes. In case of fusion of suppurative follicles, small abscesses may appear in tonsils. Typical macroscopical appearance of follicular tonsillitis you can see on these two photos. Purulent variant of tonsillitis is characterized by enlarged tonsils due to edema and infiltration by neutrophils. Purulent inflammation usually has a diffuse character, phlegmon, or sometimes is limited, like small area, in the manner of tonsil abscesses. Transition of the purulent process to the adjacent tissue and dissemination of infection is possible. In the microphoto you can find small abscess. Its focal accumulation of billions of neutrophils in the area of necrosis, surrounded by new formed granulation tissue with hyperemic blood vessels. Necrotic and gangrenous variant of tonsillitis are characterized by superficial or deep necrosis of the mucosa with the formation of defects with irregular edges. Such variant is named necrotic ulcerative. Bleeding in the mucous membrane of the throat and tonsils can be seen. Necrotic and gangrenous tonsillitis are observed more often in scarlet fever and acute leukemia in children. On the photo you can see macroscopic appearance of necrotic tonsillitis, and in this photo there is necrotic tonsillitis in leukemia. With digit 1 it is indicated the necrotic zone with nuclei absence and colonies of bacteria. With digit 2 there is indication of tonsil tissue with demarcation inflammation between tonsil tissue and necrotic area. In demarcation inflammation zone we can find neutrophils and macrophages. And in tissue of tonsil there is leukemic infiltration, which is typical for acute leukemia. Chronic course of tonsillitis is seen more often, and it develops usually as a result of repeated recurrences, so named recurrent tonsillitis. It is characterized by hyperplasia and sclerosis of the lymphoid tissue, sclerosis of the capsule, expansion of lacunae, and epithelial ulceration. Sometimes there is only prominent hyperplasia of the lymphoid apparatus of the throat and pharynx. Changes in the throat and tonsils, both in acute and chronic tonsillitis, are accompanied by hyperplasia of the cervical lymph nodes. Chronic tonsillitis in the acute stage is demonstrated on this photo, and picture of it is similar to the acute tonsillitis. Digit 1 indicates the area of necrosis with demarcation inflammation zone. Digit 2 atrophied lymphoid follicles. Hyperplaced lymphoid follicles are not seen in this histological cut, but they are present. And with digit 3, neutrophilic infiltration and bacterial colonies can be seen. Complications and outcomes of tonsillitis include local complications and common. Both of them are severe and can be potentially lethal. Local complications are associated with the transition of the inflammation to the surrounding tissues with formation of paratonsillar retropharyngeal abscesses, phlegmonous inflammation of the throat, and thrombophlebitis. Spreading of infection to retropharyngeal fatty space can lead to dissemination of purulent exudate following the fatty spaces of the mediastinum, with development of severe complication, which is purulent mediastinitis. And following the direction of the veins, inflammation can spread to sinuses of the meninges inside the skull, leading to potentially lethal thrombophlebitis and thrombosis of cavernous sinus. Common complications are also very severe, including sepsis and such autoimmune disorders like rheumatic fever, glomerulonephritis, and other infections of allergic origin. Gastritis, it is inflammatory process in gastric mucosa. It includes acute and chronic variant. Acute gastritis can be caused by two groups of factors, which are exogenous and endogenous factors. Exogenous factors include irritation by indigestible food, alcohol, drugs, action of microorganisms, consumption of some medicines. Exogenous factors include damaging factors like vascular, nervous, and humoral immune factors. For example, hematogenous infectious gastritis, eliminative gastritis in uremia, allergic gastritis, and others. Eliminative variant of gastritis in uremia associated with removal of nitrogen waste products by organs covered with mucous membranes. So, in uremia, not only eliminative gastritis but also eliminative enteritis, eliminative bronchitis, and other such conditions can develop, because in this condition, in uremia, kidneys cannot remove totally all waste products from the organism, and this role partially takes other organs which are covered by mucous membrane. According to the extent of gastritis, it can be divided into diffuse and focal variants. Focal variant can be fundal, antral, pleuroantral, and pleuroduodenal. Morphological types of acute gastritis are catarrhal, fibrinous, purulent, and necrotic. Catarrhal gastritis is the most often variant. Mucous membrane of the stomach is thickened, edematous, and hyperemic. Surface is covered with abundant mucous masses, with multiple small hemorrhages and sometimes erosions. There is degeneration, necrobiosis, and desquamation of the superficial epithelium. Self-desquamation leads to erosions. Glands are changed slightly, but their secretory activity is suppressed. The mucous membrane is covered by serous mucus or serous leukocytic exudate. Lamina propria is congested and edematous with diapedetic hemorrhages and is infiltrated by neutrophils. Fibrinous variant of gastritis is characterized by thickening of mucosa and covering of it with fibrin films, grayish or yellow-brownish in color. Depth of mucosal necrosis can be different, and depending on it, it can be Krupus variant of inflammation with superficial necrosis and diphtheric variant with deep necrosis of the mucosa. Purulent or phlegmonous gastritis is characterized by significantly thickened wall of the stomach due to edematous and hyperemic changes and also infiltration with pus. Mucosal folds are rough with hemorrhages and fibrinopurulent films. Exudate looks like yellow to green purulent fluid which flow from the cut. Leukocytic infiltration with large number of microorganisms with multiple macrophages, colonies of bacteria infiltrate mucus, submucous, and muscular layers of the stomach and can spread to the peritoneum, causing regional peritonitis. Necrotizing or corrosive variant of gastritis is characterized by ingestion of chemicals, alkalis or acids, resulting in destruction of the mucosa, so named corrosive gastritis. Due to such action of aggressive chemical substances, coagulative or colliquative necrosis can develop, covering the superficial or deep parts of the mucosa. Necrotic changes usually lead to the formation of erosions and acute ulcers. In necrotizing variant of gastritis, we need to mention that ingestion of alkali is more dangerous than ingestion of acids. In case of alkali ingestion, the type of necrosis is liquefactive, and there is no coagulation of the proteins. Due to this, new portions of alkali can infiltrate deeper healthy layers of the gastric wall. In case of acids ingestion, there is coagulation type of necrosis with coagulation of proteins. Due to this, in superficial necrotic area, formation of scab is possible, and this scab protect deeper layers of gastric wall from aggressive action of the new portions of acids. Complications and the outcomes of acute gastritis can be different and depend usually on the depths of destruction in the gastric wall. Catarrhal gastritis is usually accompanied by full recovery of the structure and function of mucosa. In case of frequent recurrences, it can lead to the development of chronic gastritis. Considerable destructive changes, which are typical for phlegmonous and necrotic variants, mucosal atrophy and sclerotic deformation of the stomach wall can develop. Necrotic changes can lead to phlegmon and perforation of the stomach wall. Chronic gastritis. Inflammation of the mucous membrane of the stomach with a significant role of regeneration and reconstruction disturbances. Chronic gastritis according etiology can be divided into type A, autoimmune, type B, Helicobacter associated gastritis, and type C, reflux gastritis. According to topography and damaged part of the stomach can be divided into the antral, fundal variants and also pangastritis with inflammation of the whole organ. Due to morphological changes can be subdivided into superficial variant, non-atrophic and atrophic variant of gastritis. Gastritis type A is autoimmune. It's autoimmune disease associated with the presence of antibodies to the lipoprotein of parietal cells and internal intrinsic factor, gastromucoprotein. It's important substance which is necessary to the binding and normal digestion of vitamin B12. Often such type of gastritis is associated with other autoimmune diseases including Hashimoto thyroiditis, Addison's disease and other autoimmune disorders. Gastritis type A is manifested mainly in children and elderly people. Usually it's localized in the fundal part, is characterized by sharp decrease in the secretion of hydrochloric acid till chlorhydria. That's why compensation process, which is hyperplasia of G cells and gastrostomia, develop. Organism try to compensate lack of hydrochloric acid, increasing the secretion of gastrin, which is responsible for stimulation of hydrochloric acid secretion. But there is no parietal cells which can increase such secretion, so level of gastrin is high, but level of hydrochloric acid is not corresponding with level of gastrin in the blood. Type A gastritis is accompanied by the development of pernicious B12 deficiency anemia, because, as was mentioned before, antibodies will block the intrinsic causal factor which is necessary to binding of B12, and such binding plays the most important role in hemopoiesis. Next variant of gastritis is gastritis type B, non-immune gastritis or Helicobacter pylori associated gastritis. It's the most frequent variant of gastritis in patients with chronic gastritis in our country and in the world. The most important etiological factor is Helicobacter pylori, which can be detected in almost 100 of patients. Other important etiological factors include endogenous and exogenous factors like intoxication, malnutrition, alcohol abuse, some drugs, and so on. The most important role belong to non-steroid anti-inflammatory drugs and glucocorticoids. Usual localization is untrue, however it may extend to the entire stomach, leading to pangastritis. Last type of gastritis is gastritis type C, reflux gastritis, associated with the reflux of duodenal contents into the stomach. Often occurs in people who have undergone resection of the stomach. Because pyloric sphincter is usually removed in such surgical operation, the contents from the duodenal lumen can return to the lumen of the stomach, leading to the inflammation in the stomach and reflux type of gastritis. Usual localization is antrum, where contents from the duodenum can lead to damage of the mucosa with inflammation. Levels of hydrochloric acid secretion and gastrin are unaffected. As conclusion about hydrochloric acid, let's repeat. Gastritis type A, leading to decrease in level of hydrochloric acid, even achlorhydria is possible. Gastritis type B usually is associated with increase in secretion of hydrochloric acid, and type B gastritis is usually hyperacidic with increasing level of hydrochloric acid. Gastritis type C usually is not correspondent with changes in level of hydrochloric acid. Nowadays, clinicians use updated Sydney classification of gastritis. In the left column you can find the type of gastritis, in the intermediate column etiological factors, and the last column, third, is synonyms of gastritis which can be used in scientific literature and clinical practice. Morphologically, there are two variants, which are superficial non-atrophic chronic gastritis and atrophic variant of gastritis. Superficial variant of chronic gastritis is accompanied by hyperemia, edema of the gastric mucosa, sometimes erosions. Microscopically, we can identify degeneration of the epithelium. In some areas it is flattened, close to the cube shape, with a decreased secretion, in others hypoprismatic with increased secretion. Lymphoplasmacytic infiltrate locates in the superficial parts of the gastric mucosa. Superficial gastritis is usually inactive. If it is active, then stromal edema, pronounced vascular congestion and infiltration by polymorphonuclear leukocytes and leukopedesis, leukocytic infiltration to epithelial cells, can be observed. The level of neutrophilic infiltration may be different, from moderate leukocytic infiltration in the lamina propria even to abscess and erosions of formation in the mucosal surface. Usually prognosis is favorable, but in some cases it may be transformed in atrophic variant of gastritis. When we estimate the level of neutrophils, counting the amount of such cells in the gastric mucosa can help us to put the proper stage of activity in such variant of gastritis. Another variant is atrophic gastritis. There is atrophy of mucosa and mucosal gland, which determines the development of sclerosis, indicated by arrow on this photo. Mucous membrane is thinned, number of glands is reduced. Lamina propria contains diffuse lymphoid infiltration by plasmocytes and significant sclerosis. Foci of the intestinal and pyloric metaplasia are typical. Often there are foci of dysplasia. Severe epithelial dysplasia may lead to stomach cancer. Chronic gastritis is characterized by the presence of the non-typical epithelium. It is going restructuring of the epithelium or metaplasia. In case of chronic gastritis, there are two possible types of metaplasia, which are pyloric metaplasia and intestinal metaplasia. In pyloric metaplasia, mucous or pyloric glands appear in areas of fundal glands in the body of the stomach. These glands are called pseudopyloric Stark's glands. In intestinal metaplasia, appearance of gastric mucosa resembles the intestinal mucous membrane with typical villi instead of gastric folds. That's why second name is enterolization. Intestinal metaplasia can be complete, enteric, or incomplete, colonic. The features of complete metaplasia are presence of limbic enterocytes, goblet cells, and Paneth cells in the crypts. The features of colonic metaplasia are resembling of epithelial cells by colonocytes, a lot of goblet cells, and Paneth cells are absent in such variant of metaplasia. Epithelium with metaplasia under certain conditions can be the basis of dysplasia and even malignancy. Next disease is peptic ulcer. It's chronic disease characterized by a long-existing ulcerative defect in the wall of the stomach or duodenum. In the etiopathogenesis of peptic ulcer of the stomach and duodenum, we need to mention a lot of different factors. Usually the main pathogenetic link is discrepancy between gastric, duodenal, mucosal protective mechanisms and damaging factors, which are named ulcerogenic. They include exogenous external factors and endogenous internal factors. In exogenous factors we need to mention violation of the dietary habits, bad habits including smoking, emotional stress, professional factors, medicinal effects. As mentioned before, most important effects belong to non-steroid anti-inflammatory drugs and glucocorticoids. In endogenous factors we need to remember about genetic predisposition, Helicobacter pylori associated gastritis and metaplasia in the epithelium of duodenum, overproduction of hydrochloric acid and pepsin, violation of gastroduodenal motility, age and gender. In morphogenesis of peptic ulcer, there are three consequent stages: erosion, acute ulcer, and chronic ulcer. Erosion is superficial defect resulted from necrosis of the mucosal layer. Erosion can persist only in the mucous membrane and sometimes it spread to submucous area. Erosion is healed without formation of the scar. Second stage is acute ulcer. It is deep defect, the bottom of which can reach muscular layer and sometimes even serous membrane with formation of perforation. Usually it's irregular round oval shape and it has soft edges, which is the main diagnostic feature of acute ulcer and difference from the chronic ulcer. Bottom both of erosions and ulcers usually has dirty brown color due to presence of hydrochloric acid hematine. At last, chronic ulcer, last stage of development of peptic ulcer disease, usually located in lesser curvature, mainly in the pylorus or body of the stomach. Mucosal relief is usually affected with converged folds or smoothed folds. This smooth convergence is typical for chronic ulcer and is one of the main important diagnostic feature of chronic variant comparing to acute one. Another important macroscopic feature of chronic ulcer which differentiated from acute ulcer is the hardening and raising of edges of the ulcer above surrounding mucosa. If such edges are significant, these ulcers are called callus. If ulcer is located in the pylorus or duodenal bulb, there is usually a narrowing stenosis of the digestive tract, sometimes leading to severe cicatricial complications. Microscopic appearance of the peptic ulcer depends on the stage of disease. In remission stage of chronic ulcer, the bottom of the ulcer contains scar tissue, which replaces the muscle layer, and single sclerotic and obliterated vessels can be seen. Usually these ulcers are epithelialized. Acute stage of the ulcer is accompanied by formation of 4 typical layers in the bottom. They are: the most superficial layer is fibrinous purulent exudate. It is characterized by presence of multiple neutrophils and fibrin threads. Second zone is zone of fibrinoid necrosis, where nuclei in the cells are absent and necrotic zone is infiltrated by fibrin. Third area is granulation tissue. It is immature connective tissue with a lot of blood vessels, multiple fibroblasts, and lack of collagen fibers. Inflammatory infiltration is usually present in granulation tissue. At last, fourth layer of the ulcer in the acute phase is fibrous connective tissue. It is mature variant of connective tissue with sclerosis of the vessels and reducing of the vessel number, less amount of fibroblasts but pronounced and multiple collagen fibers. Complications of peptic ulcer need to be mentioned separately and discussed in details, because the complications are very dangerous and almost all lethal outcomes of peptic ulcer disease originates from its complications. There are 5 groups of complications of peptic ulcer, which are ulcerative destructive complications, ulcerative cicatricial complications, malignization, inflammatory complications, and combined. Combined complications, it is possible combination of 2 or more complications which were mentioned before in 4 other groups. Let's start our detailed discussion from ulcerative destructive complications, which include penetration, perforation, and hemorrhage. Perforation, it is formation of pathologic orifice in the wall of the stomach or duodenum. In this case, the lumen of stomach has direct connection with abdominal cavity, and perforation is usually accompanied by peritonitis development. First, it will be chemical peritonitis due to aggressive action of gastric juice with hydrochloric acid and with enzymes, but later microorganisms will come to the area of inflammation, inducing local and then diffuse fibrinous purulent peritonitis, which is potentially lethal. Penetration. Penetration is another destructive complication of peptic ulcer and associated with spreading of ulcer into the adjacent organs. The bottom part of ulcer penetrates and affects surrounding organs and tissues, which can be pancreas, it can be left lobe of the liver in rare cases, even gallbladder, it can be spleen, it can be colon transversum, it can be loops of small intestine, and it can be omentum. So, when we are speaking about penetration, there is no connection between lumen of the stomach and the abdominal cavity, but there is covered defect in the wall and this covered defect can induce inflammation into the adjacent organs and tissues. For example, in pancreas, it can induce pancreatitis, even with pancreonecrosis and subsequent peritonitis development. Last destructive complication is hemorrhage. Hemorrhage is usually associated with severe bleeding from the blood vessels of the stomach and can be potentially lethal if the affected blood vessel is enough large, and such potentially lethal hemorrhage can lead to hemorrhagic shock and even death. Ulcerative hemorrhage can be recognized by typical morphological manifestations and clinical signs. Clinical signs are not only the typical signs of acute anemic syndrome, but also specific appearance of vomiting masses and specific appearance of the feces. In vomiting masses, vomiting has appearance of coffee grounds. It is viscous contents with dark brown, even blackish color. Such color is due to presence of hydrochloric hematine in the vomiting masses. Speaking about feces appearance, they also has blackish tint and viscous consistency due to presence of the blood and presence of hydrochloric hematine. That's why typical appearance of the feces. Ulcerative cicatricial complications include stenosis of duodenal bulb, pyloric stenosis. These complications are associated with excessive growth of connective tissue in the wall of the stomach, in the pylorus, or in the wall of duodenum. Ulcerative cicatricial complications can lead to severe condition which is named pylorostenosis. In this condition, the food engulfed 1 or 2 days before can accumulate in the stomach till the moment when it will be evacuated due to vomit. In this case, vomiting masses has very bad smell, and in investigation we can detect the food which was eaten 1 or 2 days before. Of course, the normal passage of food is impossible through gastrointestinal tract. Next complication is malignization. Malignization, it is formation of cancer in the stomach. Also very dangerous complication and with potential lethal effect on the patient. Inflammatory complications are not such severe as 3 above mentioned groups. They include spreading of inflammatory and necrotic process from the ulcer to adjacent areas of the gastric wall or duodenal wall and include gastritis and duodenitis. If it will spread to adjacent fatty tissue, we can speak about perigastritis and periduodenitis. And combined complications, as I told before, it can include any of the above mentioned 4 groups. Next disease is appendicitis. Appendicitis, it's inflammation of the appendix vermiformis. It's the most often surgical pathology, and majority of surgical operations are performed due to such disease. Etiopathogenesis of appendicitis include the obstruction of the lumen of appendix by fecolite, which is stone formed from the dense hardened feces. It can be due to hyperplasia of lymphoid follicles in the submucous layer of the proximal part of appendix due to some diseases of infectious origin in GIT. It can be blockage of appendix lumen by scar and narrowing it by scar, for example in case of chronic typhlitis, inflammation of the cecum. It can be blockage of the lumen of appendix with accumulations of helminths, especially in poor countries. Nevertheless, increased proliferation of microorganisms such as Escherichia coli, Streptococcus faecalis and other normal bacterial microorganisms will start due to obstruction of the lumen. It will be the best conditions for multiplication of bacteria, and this multiplication of bacteria will induce inflammatory damage first in the mucous membrane and then in the deepest layers of appendix wall. Acute appendicitis can be divided into non-destructive types and destructive types. Non-destructive types are simple appendicitis and superficial appendicitis. Destructive are phlegmonous ulcerative, apostomatous, and gangrenous types of appendicitis. Morphologically, we'll start from non-destructive forms, and first type is simple appendicitis. Simple appendicitis usually exists during few hours and, if is not treated, will transform into more severe form. Because clinical picture of simple appendicitis is not very clear, pathologists and other doctors very rarely encounter with such type of appendicitis, because very soon it will transform to other more severe form of this disease. In simple appendicitis, appendix is thickened, serous membrane is dull, has multiple hyperemic injected vessels. Stasis of blood in capillaries and venules, edema, hemorrhages, sometimes accumulation of siderophages is observed. Put your attention that in simple appendicitis there is no leukocytic infiltrate in the mucosa, and there is no leukocytic exudate in the lumen of appendix. There is no pus. Only one thing that we can see in microscopic examination is leukocytic margination and leucodiapedesis, only beginning of formation of primary affect. But as I told before, because of short duration of such pathology, we can very rarely see simple appendicitis, because in few hours it will transform to next type, superficial appendicitis. In superficial variant, appendix becomes swollen, serous membrane is full-blooded and dull. But there is no fibrin films on the serous membrane like in other types of appendicitis, like in destructive types. In the mucous membrane sometimes we can find superficial defects, erosions, which are usually covered with fibrin films. In this type of appendicitis we will see already formation of primary Aschoff affect, which consists from leukocytes, so we will see infiltration, but this infiltration is located only in the mucous membrane and submucous area, and usually not spread to deepest layers, not spread to the muscular layer, and it is not spreading to the serous membrane. So only mucosa is affected. We can find neutrophils. Usually Aschoff primary affect has wedge shape the base of which is located towards underlying tissues, apex towards the lumen of appendix. Phlegmonous and phlegmonous ulcerative variants of appendicitis. In these variants, appendix is enlarged, serous membrane is dull, full-blooded, covered with fibrin films. Wall is thickened, purulent contents are released from the lumen. Diffuse infiltration by leukocytes of all layers of the appendix, including muscular layer and serous membrane, and sometimes even spread into the adjacent fatty tissue with development of periappendicitis. We can see billions of neutrophils in all layers of appendix. If mucous membrane become ulcerated and we can find deep defect in the mucous membrane, we name such variant phlegmonous ulcerative appendicitis. Such type of appendicitis sometimes can be complicated with perforation. Apostomatous appendicitis is corresponding to the phlegmonous variant. Macroscopically, it has almost the same appearance, but the difference is in the type of purulent inflammation. In phlegmonous appendicitis, the inflammation is diffuse, but in apostomatous appendicitis, it has appearance of small microscopic abscesses in all layers of the appendix wall. We can find necrotic debris in the center and neutrophilic leukocytes around these abscesses areas. Gangrenous variant of appendicitis is characterized by severe necrosis. There are two possible mechanisms of development of necrosis. Primary gangrenous appendicitis happens if thrombosis or thromboembolism of mesenteric artery of appendix occur before necrosis. Due to severe acute ischemia, necrosis is formed, and after that, inflammation will join to the necrotic process. So in primary gangrenous appendicitis, first there is thrombosis, after that necrosis, and only after that inflammation. Opposite variant is secondary gangrenous appendicitis, when thrombosis in the mesenteric artery of the appendix happens due to the development of periappendicitis, due to complication of inflammation. So the consequence is another. First, it will be inflammation, phlegmonous or phlegmonous ulcerative appendicitis usually. After inflammation will spread to periappendicular fatty tissue, it will be periappendicitis and thrombosis of the mesenteric artery of the appendix. So thrombosis comes after inflammation, and only after thrombosis severe necrosis develop. Macroscopical appearance. Appendix is significantly thickened, earthy gray in color, with fibrinous purulent deposits. The wall is flabby, easily perforates. There is edema, hemorrhages, leukocytic infiltration, and necrosis of the entire wall of the appendix. Microscopically, we see pinkish eosinophilic masses of necrotic debris and purulent contents in the lumen. Chronic appendicitis is a very rare condition because there are usually two possible variants for appendicitis. If it will be treated, the appendix is removed and the pathologist will see a picture of acute appendicitis. If it is not treated, it will be complicated by peritonitis and patient will die. Sometimes, in case of low activity of inflammation and decreasing in immune response of the patient, appendicitis can take chronic course. Chronic appendicitis is characterized by the presence of sclerotic and atrophic processes, on the background of which signs of inflammatory and destructive changes can be seen. There are adhesions with adjacent tissues which are formed from fibrin threads undergoing sclerosis. If there is cicatricial obliteration of the proximal part, serous fluid can accumulate in the lumen of appendix and cyst is formed, which is named hydroappendix. If the contents of the cyst is mucus, this complication is named mucocele. When such cyst ruptures and the contents enter the abdominal cavity, cells can be implanted into the peritoneum to cause tumor-like peritoneal pseudomyxoma. Speaking about appendicitis, we need to mention two other conditions which are similar to appendicitis. They are appendicopathy and pseudoappendicitis. Appendicopathy is a pathological condition with a clinical picture corresponding to appendicitis, but it is caused by impaired motility of the appendix. So, clinical manifestations are similar to appendicitis, but there is no inflammation in appendix, and the clinical syndromes, especially syndrome of the pain, developing due to spasm and impaired motility of appendix. So it's transitional condition, and it is treated not only by our manipulation like doctors, but it is usually cured by itself without any consequences. Pseudoappendicitis or false appendicitis. It is a symptomocomplex that resembles appendicitis but is caused by other diseases like peptic ulcer disease, urolithiasis, cholelithiasis, adnexitis, etc. So, in pseudoappendicitis, the clinical manifestations are similar to appendicitis, but the reason of it is inflammation of other organ, including adnexa, including gallbladder, stomach, and so on. But the symptoms are similar. No inflammation in appendix, but symptoms resemble inflammation in appendix, and the reason is in other organs. It is pseudoappendicitis. Thank you for attention. Put a lot of attention to your digestion and to food that you eat, because you know there is famous phrase: the man is what he eats. Don't forget about it, and good luck.